trying to improve certain things. So, okay, let's get through neuro. Normally, again, this isn't so much just going over like basics like traumas as well as demyelination issues and things you probably will see, especially if you work in the ED in regards to like CVA and bleeds and so forth. So again, hopefully that this will affect, you might see this in whatever field specifically you're working in. One thing, which normally is again part of what residents are expected to know and NPs, especially by by the time you're graduating, is how to read CSF fluid, cerebrospinal fluid. Can we do a mini exam review after this class? Well, we could try. Let me try to get through this. Yeah, I can maybe go through the outline with you. We could always try. Okay. So, I'm going to show you a picture later of the actual brain and where the cerebrospinal fluid is created. It's within the choroid plexus, which are within the ventricles. You have 4 ventricles within your brain. And from there, cerebrospinal fluid enters the subarachnoid space. It goes down towards your spinal cord and reabsorbed within the arachnoid villi. And then it's drained. This becomes like this cycle back into the jugular veins and so forth. So normally cerebrospinal fluid, I don't know if anyone here works in neuro or if anyone here works with lumbar punctures and you see this, preferably the fluid is clear and colorless. However, a few things you should know. If you see some turbidity like cloudiness in it, that means there's protein cells in place. It could be due to some sort of infectious process, microbial pathogens, some sort of combination of these things or some cells in place. Blood can also be seen within cerebrospinal fluid. Usually doesn't mean anything. It's iatrogenic, meaning it's not like a pathology base. It could be just due to like damage in the process of doing the lumbar puncture. But it could also be due to some sort of like actual disease process, like a ruptured aneurysm, a bleed, something like that. If you were to do the lumbar puncture and it comes back and it's bloody, when you actually spin it, the top part, we spin blood in my clinic. So it's funny how when some nurses come in, they've only been in the hospital, they're like, what is this thing? I'm like, it's a centrifuge, like to spin your blood. When you spin blood, you get your red blood cells, white, and plasma. You've seen green. I'm interested to hear that. That's problematic. When you actually centrifuge it, if the blood is usually like not concerning, the last tube of that spin should be clear. Especially like the top of that plasma area shouldn't have any blood in it. If there is some sort of, usually like some pink or other type of color, and I'm curious here about this green, there could be some like a long-term bleed or some other type of infectious process. So here I just wrote down pink color makes sense because if for a bleed, because of course blood breaks down to bilirubin, and it's when that happens with ruptured red blood cells, you end up with oxyhemoglobin in the cerebrospinal fluid. But normally, if it's a short bleed, you'll see it within the first 2 hours after the bleed, and then usually within like 3, not more than 4 days, it goes away. By definitely after the week, it's completely clear. Versus some other type of breakdown, you're going to see like a longer bleed. So something that's more, I'm trying to think more long-term, like a subarachnoid bleed. That's going to last longer. You're going to actually have that xanthochromia in the cerebrospinal fluid itself that lasts enough to last up to a month. So again, if it's a shorter, like something was nicked, it should go away within the week. And you really just want to see where that is with the patient. To determine, and by then, normally with a CT or an MRI scan, you're going to know what kind of bleed you're dealing with. Oh, what happened to my slide? Okay. Trying to think, is there anything else to tell you? So the difference between the short bleed, the longer bleed, the xanthochromia is that is actually bilirubin breakdown causing that color change. And again, it should all eventually go away depending on, as long as the bleed is being resolved. Cerebrospinal fluid does have protein, it has glucose, it has white blood cells normally in it. But you can tell a lot about cerebrospinal fluid and the disease process a person's experiencing based on the actual numbers, like a lab value. So protein normally in fluid, cerebrospinal fluid, is between 15 to 45. Um, Coming from the plasma, so you're going to see prealbumin as well as albumin. If you're seeing more, right, so more than 45, normally you're thinking that there is some sort of acute inflammation happening due to, we talked about this like first day of this class, right, that permeability that's happening within the vessels. So if protein is coming in and is greater than 45 when you do the CSF, again, you're thinking more of that inflammatory process. Um, in regards to glucose, you could actually, I don't know if anyone's done this, and if you do deal with cerebrospinal fluid, try this out next time if you have a person's finger stick. So you actually check their serum glucose level 30 minutes to an hour and a half before the actual lumbar puncture. Take that number of their glucose levels within the serum and multiply it by 0.66. And that should be about estimate the number of the glucose that's within their cerebrospinal fluid. So again, multiply the serum sample that you get about 30 minutes to an hour and a half before the lumbar puncture and multiply it, and it should give you an idea as to what the actual glucose amount that you get within their cerebrospinal fluid. If it's less than that, then that's considered, the term is hypoglycosuria, and that means less, like almost like a hypoglycemic state for the cerebrospinal fluid. And when you think about that, it's usually because there's some sort of pathogenic process that's eating up or utilizing that glucose. So we're talking about like something less than 40. So what eats up glucose? Infections process, right? I'm thinking about malignant cells, tumors, exactly, cancer, things like that eat up glucose. So if you have a less than expected, let's say less than 40 glucose, then I'm thinking there's some other type of process happening that's taking up that glucose. It could be a defect in the glucose carrying system, like you might see in meningitis, which we're going to talk about. So like an actual transport glucose issue. But normally, again, I'm thinking some sort of pathologic process is happening. And then in white blood cells, you can actually tell, it's pretty indicative when how you read the different types, like a differential of white blood cells. Normally, it's between 0 to 5, normally for white blood cells in CSF. Neutrophils are pretty much never normal in the CSF. And if there's an increased amount, of course, you're always thinking some sort of infection. Due to, and again, we're going to talk about meningitis, due to some sort of microbial disease process. If there is usually bacterial, especially bacterial meningitis, you're going to see neutrophils there. Again, normally you wouldn't see, if the person doesn't have any disease process going on, you wouldn't see any neutrophils. In viral meningitis, you're thinking more lymphocytes come on pretty quickly for a virus. And then when it comes to fungi, normally, again, lymphocytes, neutrophils really, again, specific to bacterial infections and meningitis. And I think same thing, we talked about this, right? How neutrophils are really that first white blood cell to come in during an infectious process. And then I put in here parasitic meningitis, which is more so like, let's say third world countries, like the helminth worm, things like that, that can actually cause inflammatory process and other forms of meningitis. You would see more like eosinophils. Would there be tumors and infections in brain only take? Would these be tumors and infections in brain? Sorry, Corey, I don't understand. I've been reading a lot today. You know what's really bad? I've been doing my track changes for my dissertation, and my chair keeps putting these like comments on the side, and same thing. I'm like, I don't know what she means by this. Sorry, so I'm probably in a PTSD. Go ahead, Corey. What was your?
No, I just meant like, are these tumors and infections that are only in the brain that are taking from,
Oh, no, no, no.
or
Like
like
anywhere.
anywhere in the body?
Anywhere in the body could be taking up this glucose. Oh, good question. Yeah, it's not solely to the brain itself, but because it's anywhere that your glucose is being eaten, a certain amount is supposed to overflow into CSF. That's a good question. And that tumor, wherever it is, could be in the lungs, wherever it's utilizing it, it's going to be less overflow into the cerebrospinal fluid. Good question. Sure think anything else? Well, we're going to get into meningitis in a second, so we'll get more into that. So this is a placement of so you don't really see the first and second ventricles because they're mostly, I don't know if you see my mouse, like up here. Your third and fourth ventricle space is here. And this is where the choroid plexus is that creates cerebral spinal fluid. And then it drains down into the subarachnoid space and then filters up to your system through, and then sort of drains out through your carotid. So the arachnoid villi, is that listed up here? Yeah, it's up here. Sort of reabsorbs your CSF fluid. This is more just for so you know anatomically that process. So again, it's created here, comes down, that is subarachnoid space, and then reabsorbed within the arachnoid villi. And that's usually how the normal cycle of cerebrospinal fluid is supposed to flow. In saying that, there is a pretty, I think it's common enough, I've seen my share in the neuro units of hydrocephalus. And so knowing the anatomy of it is important so that you understand the differences. There's really three types of hydrocephalus. There's communicating, non-communicating, and there's what's called a normal pressure hydrocephalus. Communicating, the way I think about it is like how something communicates, it's connected. So it's not obstructive versus in non-communicating, there's literally something in place, like some sort of obstruction that's preventing the flow of cerebrospinal fluid. So that's how I make a distinction between those two. So in the non-obstructive communicative, exactly what it sounds like. There's just more, maybe more like an increased production of CSF, which is then causing hydrocephalus. So when you think of hydrocephalus, I'm gonna go back. I think names are very important so you understand that. Hydro meaning water, cephalus meaning your head, brain. So that just means water in the brain. So when you think about the terms, have to memorize it, just know what the terms mean. So if you have too much fluid in your brain and the head, that could again be due to an increased production. So there might be like a tumor, a papilloma within the choroid plexus causing more production of CSF. Or there could be, and I think this is where it gets confusing because we use the word obstruction in a non-obstructive space. But all this means is that there's still movement of the fluid. There's still fluid communicating between the ventricles. But in another way this could happen is there's an obstruction in the reabsorption. So the fluid itself is moving, but the reabsorption that's supposed to happen at the arachnoid villi can't because something's preventing that, like a tumor, maybe some scarring, some sort of like hemorrhage process in place that's preventing the actual reabsorption of the fluid. In both cases, that's considered communicating, again, because the fluid itself is moving freely throughout the ventricles. Versus in a non-communicating obstructive, there's literally an obstruction preventing that flow, preventing that communication. So there could usually, the most common in newborns is the stricture of the aqueduct of Civilis. And I don't know if you see this with babies with hydrocephalus. Again, this is usually the most common form of hydrocephalus in children. You could also have a tumor in the fourth ventricle. There could be scarring at the base of the brain. But in this case, the fluid is there, but it's not communicating. It's not moving within the spaces. It's stuck within that ventricle itself. Samantha, go ahead.
Can you please go over that
Yeah.
about the fluid flowing freely, but the obstruction part?
Right. So I think, so what I was saying was we use the term obstruction in explaining the non-obstructive hydrocephalus. So when you think about communicating non-obstructive hydrocephalus, I think about what's communicating is the fluid. The different ventricle spaces are communicating. So fluid is going from the first to the second, second to the third, third to the fourth space, moving within the subarachnoid space to the arachnoid villi. So it's communicating, it's moving. Either there's just too much fluid or it's not properly being reabsorbed. Versus in a non-communicating, the ventricles are not communicating to each other. Fluid is not moving from one ventricle to another space. There's literally something preventing that movement of fluid. So that's how I make a distinction between non-communicating and communicating. A tumor is creating more. So you can either have a tumor that's preventing absorption, or yes, you can have a papilloma that's creating, that's almost like irritating the choroid plexus, that's causing more CSF fluid. Thus communication is still happening between, exactly. So the tumor itself is causing either more production or it's preventing absorption. However, in communicating hydrocephalus, there's still, again, that free movement and communication between the ventricles. Exactly, Matthew. Yep. So that's how I make the distinction. And again, versus obstruction, there's literally an obstruction. There's something in place that's preventing that communication from happening. And then the third would be a normal pressure hydrocephalus, where there's still an over amount of fluid in the brain. However, in this case, the ventricles are actually dilating, so it's making room for it. So there's it doesn't appear to actually have large, like if you were to actually test the pressure amount, it's not as much as a regular hydrocephalus, because the ventricles are giving way and dilating because of the increased CSF. But because the ventricles are dilating, they're actually changing the anatomy of the brain itself, which can cause dementia in adults. It's usually idiopathic in nature. If you were to drain the CSF, though, it actually is reversible. This form of dementia is reversible. And people usually present, and this is more textbook, as urinary incontinence, gait instability, and a form of dementia. But normally it's pretty acute. I'm trying to think the cases I've seen. It was like pretty like quick onset. And that's how when you're making your differential diagnosis, it's not like Alzheimer's where it was like the slow growing thing that you saw over time. This is like a 48 hours, like, whoa, what's happening kind of thing. And then you do a scan, you're like, oh, this person has hydrocephalus. My grandma had that and had to get a shunt place. Oh, thank you for sharing that, Catherine. Yeah, so you can actually resolve this pretty quickly just with shunt and fluid drainage. When it started showing Catherine, did they think she was in a dementia state, or did it happen more acutely? Because people usually catch on pretty quickly, like, oh, like this is pretty, if you watch someone, you could tell like how acute or if this is more of a chronic issue. They thought it was dementia, but definitely, yeah. And people, I think, are quick. And I think as clinicians, I have to tell you, you have to be patient and take time and listen to the history. Because people are like, oh yeah, dementia. And I'm like, but look at the time frame, like look exactly, the person's also incontinent. Incontinence has something to do with dementia early on, which we're going to talk about also today. Is midline shift from hemorrhage that puts pressure on ventricles cause non-communication hydro? Yes, it can. If that, we're going to talk about herniations. If the herniation causes a prevention of from fluids to move from the ventricle, then yes, that would be considered non-communication. So any type of like anatomical change preventing fluid motion would be considered non-communicative. Awesome. Okay. Let's see. Oh, she's good. And yeah, just have to watch the shunt and checkups but the shunt, oh my God, makes such a big difference in patients. I mentioned in the previous slide about babies' hydrocephalus. There is the congenital stenosis that can occur within usually it's here, actually, I can show you the picture. I think the picture helps make more sense. There could be a stricture here. If you look, see where the fourth ventricle and third ventricle here, there could actually be a narrowing in this space, which prevents fluid from going through the third to fourth ventricle, and that could cause hydrocephalus in children. And this is called a cerebral aqueduct stenosis. Stenosis, again, meaning narrowing. That prevents, again, that fluid from third to fourth. So because you guys are paying attention, is this communicating or non-communicating? That's stenosis. If you're preventing fluid from moving from third to fourth ventricle. Perfect, non. Okay, yay, we're together. So because of this, and the fluid can't move because of that stricture, fluid then builds up within that third ventricle space. And again, this is the most common seen in newborns. Fluid is still being produced, the cerebrospinal fluid within the choroid plexus at a normal rate. It's not an overproduction. It's just the inability of that fluid to move. So I put in here some anatomical, which I think that there's enough to test you on. I'm not going to get into the nitty gritty of the different types of anatomical differences, but this is more, again, for your knowledge. If you work in neuro, especially if you work with babies, I think this is important to know. Flowing from the lateral ventricles to the third ventricle through the intraventricular foramen of Monroe. So if you actually were to look at the picture of the brain where the first and second ventricles are, is really just saying how that those fluid flows from the first, second ventricle to the third ventricle. And from the third ventricle to the fourth, the body, it goes through the cerebral aqueduct, and that's where you see that stenosis occurring. Flowing from the fourth ventricle to the subarachnoid space, it goes through the foramen meninge and the Luschka, which I don't even know how they get these names, but again, that's the anatomical like passageway of cerebrospinal fluid, which again, if you work in with newborns with hydrocephalus, this could come up, especially when they in the radiology reading of what they're seeing as being structured and where they're seeing anatomical changes. So I wanted to put that up there for our pediatric, especially if you're in acute peds. So we won't be tested on how, no, I'm not going to be like, I don't even try to come up with a question, but I'm not going to ask which anatomical would no, like the actual, these names here, like the foramina, people's names, I guess, and foramen of Monroe. No, I'm not going to test you on that. But, okay, because I'm always trying to give up some practice questions. Maybe, something like a nurse, a patient comes in, or yeah, a patient's is brought in by her family, regarding concerns of recent, and this is actually going to be tricky. This is actually a good one because we also talk about dementia later on this lecture. But if I ask you like with new acute onset of dementia, however, the nurse reports normal pressure of hydrocephalus in the brain, the nurse would expect which finding on CT scan. So the thought is that the person does have probably normal pressure hydrocephalus, and trying to think how I would then put the answer choices. It would have to be something, actually, no, I think that might be too complicated because then you would have to know how to distinguish that on radiology. This is how my brain goes when I'm creating practice questions. Or maybe something like a patient has been recently diagnosed with choroid plexus papilloma. The nurse is concerned regarding which possible outcome, and it would be something to do with, I wouldn't say probably not like non-obstructive hydrocephalus. Is going to be something about fluid buildup in the brain, but again, trying to brainstorm how to the answers are never like that, like non-obstructive hydrocephalus, trying to make sure you understand the connection between that and the pathophysiology of it. Would you do a UA to rule out? Oh, definitely. If any older person ever comes out with a dementia or some sort of confusion, the first thing you do is a UA, especially if it's acute onset, definitely. Thank you for asking that, Laura. And that's more of a diagnostic issue. So again, for the purpose of this question, not asking about anatomy, more so asking about presentation and expectation of finding. So again, if it's a papilloma, if the tumor, let's say, is scarring, which might prevent reabsorption, that's going to be non-obstructive hydrocephalus. If it has to do with maybe more of a stricture, it's more of a obstructive type of hydrocephalus, that's sort of how the questions here would be framed. And then understanding that in children, usually it's due to, again, that stenosis, the cerebral aqueduct. And these children, because, and it's about babies, their cranial sutures are not yet closed, right? So that's why they have those soft areas, right, of the brain. When hydrocephalus occurs, you're going to see more of it's open, but it's going to be more like there's a bounce to that. Have you guys ever touched that? It sort of freaks me out every time I touch a baby's like head that's still open. But in people with hydrocephalus, that enlarging head circumference causes that dilation, and again causes more like that bouncy region of their fontanelles. Okay, so knowing that, you guys are familiar with children and fontanelles. I know I have some peds people here, which would be, but if you're adult people, you might be like, what is she talking about? Okay. Moving on. So hydrocephalus, know the differences between the types of hydrocephalus. Spinal cord lesions, also known as syringomelia. These are usually due to trauma. They're actual degeneration of the spinal cord with like cyst developments on the cord itself. It could be due to some sort of malformation of the brain, and we call that the Arnold-Chiari malformation, which I don't really use that, but the times I've seen is really due to trauma. It could be from C5 to T1, if you guys remember your different vertebrae. And depending on the placement, shows like how a person is the clinical manifestations. So normally in the cerebrospinal cord, and I'm going to show you a picture of this, the placement of the lesion normally affects loss of pain and temperature. So these are people who, I don't know if you've seen patients like this, where they don't recognize when they're touching like a hot stove or some sort of, this is when you do your neuro testing, when you guys get into your, because you haven't had this, right? Your, what do they call the class? It's like, physical assessment, I think is what you guys have, right? Thank you, Gabrielle. When you actually do the like writing in someone's hand and like touching with the different ends of your scope, I do things like that. Have you guys had a health assessment yet? Not yet, right? Okay. When you do that, this kind of testing is actually really important because what you'll notice is they actually have fine touch and position sense. They don't have pain and temperature sense. So when you touch them with like actually like the tip of, I usually will use a tip of not really sharp, but something more pointed in my office, they won't really sense that. Versus if you try to like draw like an 8 in their palm, they'll sense that. It's really interesting. And their position sense and their upper extremities. So like they have some changes almost like up here in their shoulders, up down through their arms, where there's this distribution of where they can sense or they lose their sense of touch in these areas. And that's because of where the lesions are developing on the spinal cord tract, which I'm going to show you. So actually, I'm going to show you that now. The anterior white commissure is involved. So the lateral spinal thalamic tract here is really where those lesions are normally found, and that's really what's affecting their sense. Versus when it starts, if the lesion were to grow, that's when it can come over and then start affecting the motor side. But initially with these lesions, these people are going to first present with inability to differ pain and temperature. If it were to grow and then it gets into like proprioception and light touch, and again, it has that cape-like distribution, which I usually show a picture of that. And again, that's really about the placement of where the lesion is. Proprioception, again, is like the ability to, with your hand, with your eyes closed, be able to tell what's in your hand, I guess, is like, trying to give an example of that. Well, I was making this thing between knowing what your position versus knowing like I just drew like the number 8 in your palm, right? So proprioception is the ability to know like when you put your hands like this in the front and you have someone close their eyes to make sure they don't like sway, and then also being able to sense that light touch. Yeah. I'm trying to think what we use in when I teach assessment, the different types of testing we do for that. But yeah, it's really just your body's ability to sense placement with your eyes closed. If the lesion itself were to, again, expand, I mentioned this, to other tracts, it could then lead to, like I mentioned, other forms of like proprioception would then be affected, like touch could then be affected, and then if it moves over to your left, the part of the column, then it's more of a motor problems. So that's when you start seeing things like weakness, decreased muscle tone, just issues with motor neuron movements. Then it could also change what's called the track that's there. If the lesion affects the areas, it turns to what's called Horner syndrome. And again, let me just show you the picture I'm trying to refer to. Oop. This here, the lateral, that's what I was going to say, this lateral cortical spinal tract. And then later on, it could lead into the ventral cortical spinal tract. And again, this is more so leading to muscle tone, weakness, atrophy could occur. And then the Horner syndrome is really like droopy eyelids, constricted pupils, decreased sweating again. And that's because it's disrupting that lateral horn. And again, don't get too caught up in the anatomy of it specifically. It's more about understanding the placements within that right side track, affecting more sensory, and then the ability to expand, and then it cause more of like muscle atrophy and Horner syndrome. So knowing the distinction in that too, and expectations in regards to the clinical manifestations of this. Okay. So we talked about, again, hydrocephalus, cord lesions, and then meningitis I was getting into earlier about cerebrospinal fluid. And I think you'll definitely see your share if you have it of meningitis. So something definitely you want to know. Meningitis in itself, exactly what it sounds like, inflammation of the meninges, specifically the leptomeninges, which is the pia and the arachnoid layers together. We call that the leptomeninges. If you guys remember your the meningeal layer is your dura, subarachnoid, and pia matter, right? And so that lays between the brain and the skull. And I'm going to show you a picture of that. When you have inflammation of those layers, specifically the pia and the arachnoid, we call that meningitis. And it can be due to various reasons. Again, I would think that you've seen your share probably of meningitis in the hospital. In neonates, usually due to a group B strep or E. coli, it can, or listeria. Again, I've seen, I think, more E. coli and strep B, streptococci. Children, teenagers, and meningitis. Elder adults, streptococcus pneumoniae. So just a list here of different expectations or cultures that you might find related to the causing meningitis. H influenza, especially non-vaccinated, and that's more of a concern now. I don't know if you guys have seen that, where H influenza is actually causing meningitis. Coxsackie virus, pretty common, can lead to, so Coxsackie virus in itself is common, leading to meningitis, not as common, but definitely can happen. And then in our immunocompromised patients, I'm thinking of my patients with poorly regulated like HIV. You could even have meningitis related to fungal origins. So keep that in mind. Meningitis, classic textbook appearance is that triad of the headache, nuchal rigidity, right? So they're like pain, inability to move their neck. Again, you guys could share how you have seen your patients present with meningitis. Photophobia is common. Vomiting, projectile vomiting I've seen with meningitis. Altered mental status states can also be present. Depends on, again, bacterial versus viral. You know, I've seen really bad bacterial cases of meningitis. So again, I don't know if you guys have seen that in presentation. Normally, the best diagnosis would be, again, that lumbar puncture and looking at cerebrospinal fluid. I mentioned this previously. So bacterial meningitis, thinking again, neutrophils, that low CSF glucose, because again, glucose is being eaten by the bacteria. The gram stain in culture often identifies the organism. So doing the culture, getting the fluid, staining it, then you can figure out like, am I dealing with E. coli or group E strep, and how to treat that. Viral, usually, and with fungal, same thing, you'll both see lymphocytes more. The difference in that viruses don't actually eat much glucose. So normally the glucose in a viral meningitis is normal. But funguses and bacteria are sort of the same, where they do eat up glucose. So that actually would probably be a really good test question. A nurse is looking at the results of a recent CSF reading in the lab from a patient diagnosed with meningitis. The nurse notices lymphocytes. Oh, what's wrong, Gabrielle? Is that bad? Because I remember what you told me. Oh, you're reading what's up. I was like, is that a bad question? That's funny. 1 week in the pizza a few weeks ago came in for a... Oh, that is, oh my God. Was the mom not treated? How old was the baby? I know, 3 weeks. So the mom must have had group B strep. They didn't treat her before vaginal delivery. That's horrid. I always wonder how that works with, she tested negative. I don't know if I trust that. So how did the baby get, now this is all like getting into, house. Okay. I'm curious how the mom tested negative. How did the baby get group B strep?
They were thinking it was environmental
Yeah, well,
or the mother was, or it was a false negative.
I'm thinking false negative, right? Like when you said that, the first thing I thought was false negative. Oh man, that's rough. Okay. How was the baby presenting?
When she first got there, she was just like a little lethargic, decreased PO intake, and she started to develop abnormal movements in her left arm. So we loaded her with phenobarbital and then intubated her because she was really tachypnic and like decreased mental status.
That is so sad.
Yeah.
Wow.
And then she ended up having like bilateral infarcts like a day later, and they palliatively extubated her. It was really sad.
That's really sad.
Yeah.
And like Chelsea's point, yeah, they usually test twice for that reason, because once the baby passes vaginally, it could be very hard. And it's such a fast onset. They deliver so quickly that you aren't able to adequately. Right, it's true. One time we were in the ED and a mom came in to deliver and she had no history of any prenatal workup at all. And it was so concerning. So, okay. Thank you for sharing that. Again, a lot of this can be, prevented in some ways. Actually, I was going to mention the listeria. I don't know if you guys are familiar. If you've been pregnant, you sort of know this when you're not supposed to eat certain foods. And I think this is more of like an Americanized thing. Like you can't eat like sushi. You're not supposed to eat sushi. You're not supposed to eat cold cuts, hot dogs. And one of the main things you're not supposed to eat, no cold cuts, is soft cheeses. And the reason to not eat soft cheeses is because of this bacteria here, the Listeria I always say that one wrong, monocytogenesis, because you're prone to that bacteria can live within soft cheeses, and normally people who are not immunocompromised, it's fine. I don't know if you guys are cheese connoisseurs, but then that actually makes the baby more susceptible later. It's crazy because I have friends who are not like Americanized, and apparently in other countries are just like whatever. And here we're like very much, you can't eat this, you can't, and she's all eating all kinds of stuff. And I was just like watching her, I'm like freaking out. So keeping that in mind. There was a week we had 2 moms on antipyrine. Oh, really? I wonder, do they eat cheese? Because our food here is so questionable I know it's right. Other countries don't have that problem. You're right. I definitely have, it's crazy. I have patients who come and they're allergic to they list every fruit. They're like, I'm allergic to apples and pear, like common fruit. And they're like, but when I go back home to Jamaica, I can eat all the fruit. And I'm like, well, then it's not the fruit. Like it's us. Obviously, we have a problem. So anyway, something to keep in mind. It's true.
Wait,
Okay.
before we started talking about babies getting things from their moms, you were gonna give us a potential test question about these different meningitis.
Oh, sorry, Gabrielle. Yeah, because you said, oh my God. And I was like, why? Is this a really bad test question? You're right. And then I said,
Well, I mean, like, maybe it's probably gonna stress me out, but
no, okay. You said last time we are gonna take the L. After the class, I was like, Gabrielle said she's gonna take the L. I was like, this isn't good. On the whole endocrine chart thing. So the question, thank you, Hannah. So the question was something like, a nurse, a patient with meningitis gets a CSF testing. The nurse reads the lab value and notices elevated lymphocytes and a normal glucose level. The nurse would expect which pathogen is causing the meningitis, and the answer would be a virus. But is that too easy? Maybe I put like
I promise you can give us an easy
something
test
like
question.
that.
And also, it's not too easy, right? You're asking us to differentiate between the different. It's levels down. Don't worry about it.
Yeah, because
it's
normally
the
when
right
we
level.
say bacterial virus, I would say like H. influenza, streptococci, like something like that. Like actually give you organism names.
No.
Definitely not.
Since we're not studying which things are viral and which things are
made it hard
bacterial.
once again.
Keep it.
Yeah.
Please have mercy. We're working full time.
No, I know this is true. I always said my bachelor's and my master's, I had no kids, no husband, and my DNP and PhD, I have kids and a husband. And when I did my my master's, I was also working more like part-time. I wasn't working full-time. So, and there was no reading day, you're right. So yes, Jacqueline. So if I said the reading was lymphocytes and a normal glucose level, then the answer would be a virus, viral meningitis. Okay, I'll keep it. When I'm going through, I'll keep it simple. Yeah, so virus is a normal glucose, exactly. So if I said the nurse notices lymphocytes maybe I might use it like like low glucose levels, then you know the answer is like a fungal meningitis, right? Okay, try to keep things simple. So So I should tell you, when we write questions, there's something called a point by serial number that tells us if it's a good question. And the point by serial, which you guys probably not like, is when a question's able to distinguish like people who do really well on the exam and people who didn't do well at all. And if a point by serial is really, you want it to differentiate like people who really know the material from people who don't know the material. So that's why things like these type of questions, you always try reading like how to make this a good question with a good point by serial so that it really does separate people who know the information versus those who don't. So those are all things to consider when we're making our exams. Please let us go. Well, usually in my experience, a third exam is usually better than the second exam, which I think most of you would appreciate. Don't know if you answered this already, but will you be expected to calculate? No, you're not going to calculate any glucose. There's no calculations on this exam at all. Okay, good. Let's see. Trauma, which again, if you work in the ED or whichever, you might see your share. So epidural versus subdural hematomas. I always like to show this picture so that you see what I'm talking about. So this is your dura mater, moving my Zoom boxes. So your dura is like this thin layer that attaches, is attached to the skull. And if you ever, you guys only have the opportunity to do like cadavers and all that. It's really really on there, stuck onto the skull itself. If you have a arachnoid bleed, right? So sub meaning below the that space, or you can have an epi, which is above, right? So epi meaning above and sub meaning below. Right? I think a cadaver, actually, it helps, I think, anatomically to put things together, but I don't think we always have those opportunities. We're across from the medical examiner's office, but I don't know how that works. So in an epidural, right? So above the dura, a bleed there, it's literally separating the dura from the skull. So if you think about that, right, to separate it, because it's so, like when I said the dura is so tightly up against and attached to the skull, it takes high pressure to separate the dura from the skull. So this really can only happen if you rupture the middle meningeal artery. So if you guys remember arteries and veins, right? So veins are very like slow, right? If you ever put an IV in a patient, right? It's not like gushing blood versus an artery has high pressure. So I want you to think about that, like anatomically, people that come in with epidural hematomas, there had to be some sort of rupture, fracture, trauma to usually the temporal bone. And that fracture then causes a rupture of the middle meningeal artery, which then allows for that slow separation of the dura from the skull itself. And you actually could see that so it comes out looking like almost like a lens on a CT scan, which I'm going to show you a picture of. And because the bleed, it takes a while for that pressure to develop. Initially, the person actually seems fine. Like if you do like an A&O assessment, like, okay, you're fine, you wouldn't actually know that a bleed is actually occurring initially. But eventually that bleed occurs, it pushes away, and then herniation develops. Movement, herniation, when I say that in the brain, is actually a movement, anatomical movement of the brain, and that could cause death. And every time I give this lecture, I always think about that actress, Liam Neeson's wife. She acted in the Parent Trap. What was her name? That's why everyone should get a CT scan regardless of how fine they feel after hitting their head. Oh, I doubt exactly, Gabrielle. That's why any patient that's like, oh, I'm fine, or they have whatever, I'm like, nope, CT scan for you. Yeah, she had a ski accident. I don't think she was wearing a helmet. I forgot her name. There was a sad story. There was a patient had a motor vehicle accident, decided they didn't need a CT scan. Was brought into the hospital, I guess went home and brought into the hospital like hours later and pretty much died when they got there because of the bleed. And they just didn't realize it initially. Yeah, Natasha Richardson, exactly.
Wait, can I tell you a really sad story?
We're full of sad stories today. Go for it.
So, and what's even more sad was that this patient was a nurse. So I work in the surgical trauma ICU. So anyway, she was walking her dog, and the dog went to go like chase after something and pulled her, and she fell and hit her head. And like she got up and thought she was fine. She went home, and then like later on was unresponsive and brought to the hospital, of course. But she ended up passing because, the family withdrew care. because she just had such an extensive bleed that it was going to be catastrophic. But she thought she was fine, like got up and walked to the house, and like her children are nurses too. It was really sad. And actually
Oh.
they were going to donate her organs, like do a DCD. But she actually didn't die in time in the
Oh.
OR. So then she got brought back to the floor and died like 2 days later finally. But oh my God, it was really
That's really oh, that's rough.
so sad. And the fact that she was a nurse, like, I don't know, I feel like you should
I
always
know,
just get
right?
a CAT
I always
scan
feel like
regardless.
we keep together in, you know, our nursing world.
Yeah, I think she might have been on a blood thinner or something. Like she had
Oh.
AFib, so she was on a blood thinner and then hit her head, and it was just yeah.
Thank you for sharing
So that
that. I
was
think,
sad.
like Jacqueline said, like, so my son plays soccer, and anytime one of the kids gets hit in the head, I'm always like, oh my God, like I always go to like the worst case scenario, like a bleed. And I mean, thank God it doesn't get to that, but like I'm always, yeah, because you don't know, like you're like, oh, I feel fine, it's fine. I think we always are so quick to brush things off. As a clinician, don't brush something off. You're always better off getting it and it's nothing versus, God forbid, you let someone go home and become something. Because with action movies, how often they, oh yeah, and like nothing happens. Football definitely. I guess I talking to you guys forever. Real quick, because it's on my head. Did anyone here watch Lessons in Chemistry? It was on Apple, I think it was. No.
I read
Gabrielle,
the book.
you read the book?
Yeah.
In the book, oh, well, now it's gonna
Spoiler
I
alert.
don't want spoiler, yeah, so forget it. Okay, never mind. He dies in the book, right?
Yeah.
Does he die in the book similar to what Gabrielle said about being pulled by a dog?
Oh, I think so. I don't really remember, to be honest.
Oh, yeah. Annie, you know what I'm talking about then.
Yeah, he dies the same in the book as the show.
So you read, okay, good. So
The
yeah,
dog, yeah.
but Gabrielle's story with the whole dog thing made me think of that. When you guys are in your break, like your 2-second break, because I think you guys, we have our final next week. You get the following week off, and then what? Semester starts again? Or what's the schedule? I don't teach in the summer for the grad students.
I think it's like end of May.
Okay, so you get a little bit more time. Oh, thank God. May 19th. Okay, good. Well, actually, no, right?
So
That's
they have like not even 2 weeks.
you don't even have 2
2
weeks
weeks?
off. So in the little time you have off, you maybe watch Lessons in Chemistry. I thought it was a good show. Yeah, I thought you guys had only like 1 week off. It was a little crazy. Normally we get at least a few weeks off. Okay, so distinguish between epidural, epi being above the dura mater and separating there, which is really hard to separate, which again, think about the artery, they need to have that artery in place to cause that separation. Versus in subdural hematoma, again, sub meaning below, it's not as difficult a bleed to occur. It's still from trauma normally, but in this case, blood is literally on the surface of the brain itself. So the dura are still intact. Blood is going on and really perfusing through the brain tissue. But what's happening, there's still a herniation developing of the brain itself because of that. It is a hematoma, right? So blood is still pooling. And there's veins in place where the brain is. I'm on my hand motions. Where the brain is, there's actually veins that's also being stretched out when that bleed is occurring. And it's the actual tearing of those veins that causes more of the damage and what we see medically within these patients. The difference in this is, again, there's this lens look under CT for epidural hematoma versus it's more like a crescent shaped, and we'll show the difference in that in a picture coming up. In both cases, again, there could be some sort of lucid moment initially. These people do progress to neurologic signs. It's usually not as, I'm trying to think of my experiences in textbook, as acute of epidural. Like once the brain herniates and the epidural and that dura mater comes apart, it's pretty much, death is pretty imminent. There is an increased rate of occurrence in the elderly because as you get older, your brain is atrophying, which is like another just sad thing to think about. But there is an age-related cerebral atrophy that's occurring. And if you think about it, you have your dura and you have your brain. So even if it's atrophying on its own, there's already sort of like this pooling occurring. If bleeding were to happen there, that's even more stretching, more aggravation of those the veins. So the rate of occurrence of those veins being damaged in a subdural hematoma is more so in the elderly because of that atrophied brain. And again, in both cases, if the brain were to herniate, that's lethal. That can be lethal in itself. So what I mean by that, I'll show you pictures here. Again, you have this epi being above the dura, and here's an example of just a ruptured bleed. So the bleeding is occurring here, causing that separation. Versus in subdural, right? So sub meaning below, there's still a bleeding, there's still a hematoma occurring here. But it's not separating the dura mater here. So it might not be as progressive like death and its neurological changes as it would be as acutely death is occurring in an epidural. And in the next, I think it's the next picture, right? So here I'm showing the veins. And what I mean by like the elderly patients is there's a space here that as someone gets older, there's more space occurring. So there's even more of this leeway because the brain is atrophying down. So when that's happening, and this is like a natural occurrence as people get older, those veins are being pulled. Now, if you think about blood pooling in this area, that's even more aggravation and more of that pushing motion of the brain itself, which then can lead to, again, worsening manifestations of a subdural hematoma. So that's really all take away from this picture. So let's see that. And this is what I was referring to in the picture. So you have like sort of the lens. Well, I mean, I don't know if anyone here is really going to be reading their if you guys read your CT scan, but lens is a thought that this looks more so is a very what's the word I'm looking for? Sort of like condensed area of the bleeding is one area, which causes, again, herniation. But this is considered the epidural type of bleed because you can almost see how the dura mater is like sort of just being pushed within and is very just condensed and compartmentalized here. Versus in an subdural bleed, it's more, I guess, it's some way spread out, has more of like this sort of like a crescent look out here. And it's the overall herniation throughout that side of the brain. So it's more spread in its hematoma. I will not show you any pictures on the exam. It might say though, like a nurse is treating a patient with a cranial bleed. The nurse notices on CT scan lens appearance. The nurse would expect the patient probably suffered from and something like maybe like an arterial, meningeal arterial bleed or some sort of temporal bone fracture, something like that leading to an epidural hematoma. Is herniation a complication of both? Yes. Or just, no, herniation can happen in either way. It can happen without trauma, which I'm going to talk about. But epidural and subdural hematomas can lead to herniations, which could lead to a faster death. It's a good question there. Okay. Okay, speaking of herniations, let's go into them. So there's different types of herniations. What I meant by that, again, in regards to the hematomas, is blood pooling and causing actual movement of the brain tissue. We see them in hematomas. It doesn't have to only be in that. Your brain can be displaced in different reasons. It could be due to even like tumor placement, increased intracranial pressure could cause a herniation. So different reasons. Where the herniation occurs and the anatomical change is really what then determines the clinical manifestation of what you see. So I think I have a picture here. Yeah. So you could have what's called the subflaxin herniation, we call it an uncinate, or I heard an uncinate herniation, or the tonsillar herniation. So just different parts of the brain where a herniation can occur. So wanted to show that picture to give you some guidance of where this is going. So with a tonsillar herniation, probably one of the worst you could have because it involves displacement. There's a cerebral tonsil, so it's really the back of the brain and to the actual foramen magnum. So if you think about anatomically where that is, it actually can cause compression of the brainstem, So once you compress the brainstem, that can go directly a person into cardiopulmonary arrest. So I think out of all of these, the tonsil herniation is probably the most concerning. So flaxen herniation, and again, I'm not going to get into the actual anatomy. There's a lot of anatomy within what I talk about within this, which I don't expect you really, unless you're in neuro and you're really embedded in it, you're not going to remember like the sigmoid gyrus, like the fasciae cerebri. Like I don't expect you to remember those things. But the subflaxen herniation, that's the displacement that it involves. The concern here really is infarction that can come from a subflaxen herniation because it's compressing the anterior cerebral artery. So if you look to where the subflaxen herniation is, and I'll go back to that picture, it's near the anterior cerebral artery, which if that gets compressed, leads to infarction, which is like the same thing as a stroke, which we're going to talk about. And then in an uncal herniation, that is more on the sides. There's a temporal herniation, lobe uncus there, so that could be herniated. And again, anatomically, it's at the tetronium cerebri. But the concern here, again, is to understand that it affects or compresses the cranial nerve 3, which is ocular motor. And these people actually present before you even realize they have an uncal herniation. There's this acute change in their eye movements and dilated pupils, which again, I'm going to show you that. So really the takeaway from this would be like tonsil herniation concern is more of a cardiopulmonary arrest because of the brainstem compression. Subflaxen herniation, the concern mostly is a cerebral artery bleed, compression leading to infarction. And uncal herniation, I'm concerned more about changes within the ocular motor, cranial nerve 3 causing changes in eye. So I think thinking about it more in that way could help keep things simple. In uncal herniations, you can also have compression of the posterior cerebral artery, which could lead to infarction of the occipital lobe. There's I think I talked about this, a contralateral harmonious hemioptasia, which is similar to, say that again?
Homonymous.
Oh, I never said it like that. I would say homonymous, but you're right, that sounds better. Which really just means it's the loss of vision, which is similar to what we talked about with the tumor placement, if you guys remember that from the from the lecture last week, right? So you have this compression, and in this case, this herniation, same kind of idea where it's compressing and making changes to the occipital lobe, and you have these changes in vision, which are actually just affecting half of someone's vision, but it's contralateral to the compression itself in this case. Again, that's not really my focus for this. It's really just understanding uncal herniation, and it's really changes in the ocular motor region, occipital lobe. It can also cause rupture of the perimedium artery, which could lead to a brain stem hemorrhage. We call that a Durette hemorrhage when it's part of the brain stem. So, yep, I think those are the main takeaways. For the purpose of a question, something
I feel like
again.
you could just make it really direct, like, oh, they have a
The patient
tonsillar
comes in.
herniation. What's the biggest risk?
Oh, I was
And
thinking
then just
more like,
and then you can just give all the options that are like listed here for different herniations, and we have to know it.
right. I've done questions like that where it's like just putting all the options out there and you have to be able to relate the two. Or doing it backwards, or a patient comes in with and the nurse is facing a patient for cranial nerve and notices cranial nerve 3, showing dilated pupils. The nurse would expect which type of herniation. And the answer would, of course, same kind of idea though, uncal herniation. Pituitary adenoma. Yeah, so last oh my god, I can't think. The endocrine lecture, yes. So you could have tumors in place that could cause compression. Pituitary adenoma is one I did talk about. I know someone else I talked about in the lecture, which then also could causes compression and then changes in someone's vision. So in this case, the the contralateral changes causing that peripheral loss of half a person's vision could also be coming due to an infarction of the occipital lobe. So I think that would be a good, maybe that's a good question to ask, like a distinction between those types of visual changes. I don't know, brainstorming how to ask these questions. Okay. Was it Gabrielle? Say that again. How did you say it? Was that Gabrielle who said it?
No,
Oh,
Jacqueline.
Homonymous. You could say,
Oh.
you could also say homonymous, but
Okay, maybe that's how I've
homonymous
always
or
heard it
homonymous.
said. I've always heard they've always been an accent on the Y. I don't know why.
Homonymous.
Homonymous, that's yeah. But then either way, I always have a hard time saying it anyway. Okay, thank you for that. So this is an example of that. So it's well, actually, it's a example of like how the vision, if someone were to look forward, and I actually have another picture of this. You'll notice a dilation of that of the pupil. And again, I'm not gonna. There's no eye exams or any expectations in that, but really just understanding how the clinical manifestation comes because of the pathophysiology is what I would want you to take away from that. And I think also on this slide, I want to make sure you make a distinction because I want to not be confusing. This cranial nerve 3 ocular motor change is what's causing that picture, the down and out with the dilated pupil, right? That is not the same thing as a contralateral homonymous hemianoptasia. Okay, that's different. That is an actual loss of vision versus this one is actually the pupil dilation and the actual change in the motion of the eye itself. Okay, so I want to make sure. So we are not expected to know the presentation of these illnesses based on the anatomical position of the herniation. Symptomology. Oh yeah, I got that you said symptomology. That I could catch on. I would say I would not ask you a question based on anatomy only. Like I wouldn't say at this place within the brain what what kind of hernia that is. I think that's just not reasonable. But I do think, oh, the symptoms, right? Like because I always think in my questions how to make you a better clinician. And a patient never comes in with like, oh, this herniation at this site, but they might come in with, let's say, this contralateral, hemioptasia, or they might come in with, or I don't know, I'm trying to think like how a person would present. Or maybe they'll have like increased cranial pressure with, I don't know. I could say on a CT scan, the nurse notices, no, I think that's too hard. Displacement of cerebral like tonsils. I wouldn't expect you to know that's a tonsillar herniation. So no, I don't think that was reasonable.
Yeah, because also we're not radiologists. Like we're not.
Right, and you wouldn't know that.
Granted, we will be looking at scans, but it's also like a professional is actually the one interpreting them and giving us the report. So we're not like expected to
You're not
read
expected to
and
read,
interpret
no.
scans.
I only ask just because a lot of these slides, a lot of the content is based on various anatomical structures. That's the only reason why I asked. I'm not begging for that to be on. Yeah.
No, I don't think you were. So the reason for that is, so depending on which board you take, and your specialty, some of them are more prone to anatomy, like the acute care. But for the purpose of this class, and I mean, this class is supposed to be focused on, in its development on all specialties for any board you might take, touching base everything from neo to geriatrics. So that's why some of this information is put in here for that reason. For the purpose of our exam, I am not going to test you solely thinking you're going to know the anatomy of something. And to Corey's point, radiology, they do interpret the scans, but if you guys ever read it, it'll say like interpretation. I don't know if you guys look at scans. I love looking at radiology interpretations. It will say herniation noted, displaced at cerebral tonsils. It'll say like those words. So you might not see the picture, but the words will be there. So understanding what that means when you read it is, important. Again, for the purpose of the exam, I'm thinking it's going to be more about, again, clinical presentation, how a person presents and how that leads you to to an answer. And I always will put, something else in there to help you along the way to get to the right answer. So I might put down like, okay, just give an example, we'll move on. A nurse notices, again, a patient's pupil dilated with rolling to the right. The nurse suspects cranial nerve 3 involvement. The nurse would expect to see what kind of herniation involved. And the answer would be ungual herniation. Or maybe in the stem, I'll put notices displacement of temporal lobe. But again, there'll be other things like cranial nerve 3 is an option, the downward out, so all of that will be in the stem to help you get to the answer. And again, that does sort of make it wordy in that way, but again, there's key words in there. Again, hopefully that helps you, leads you to the right answer. Okay. Okay, that's a picture of that. I showed you different places for herniation. Okay, cerebral vascular disorders, thinking like strokes, neurological deficits, compromising due to usually lack of blood flow, or usually it's ischemia, which is 85% of cases. So this is like a change in blood flow to the brain. So usually, again, it's ischemic. In some cases, it could be hemorrhagic, which again, I've seen my share also of hemorrhagic strokes. Your brain, of course, needs blood and glucose to function as an energy source. We know normally if your brain will start going a form of necrosis within 3 to 5 minutes of not having blood, oxygen, and so forth, and glucose to its system. So the longer you go, of course, you're more susceptible to ischemia and necrosis of the area. So, and I don't know, I know when I was a nurse, I really think about it so much about ischemia of the brain and how even things like anemia can affect that. But it's true, like even something like severe anemia can affect brain blood functioning. So we call that global ischemia to the brain. So things like even low perfusion, which even plaque development, atherosclerosis can lead to global cerebral ischemia. I mentioned anemia. So I have patients come in with a hemoglobin of like 7, 6. I'm like, this is a problem. And not just because they're about to faint out on the street and they're like winded from walking, but because also think about what's happening to their, actually there's chronic hypoxia that's happening to their brain. Of course, the obvious ones, cardiogenic shock, right? But even someone who has like uncontrolled diabetes, so repeated episodes of hypoglycemia, think about my type 1 patients with diabetes, how that affects their brain. So I wanted you to think about like not just strokes in itself, but like all forms of global cerebral ischemia and how that can affect someone's brain functioning, and even something as anemia and hypoglycemia can cause global ischemia. Gabrielle, go ahead.
What's an insulinoma?
It just means low amount of insulin to the low amounts of insulin to the brain is really the definition of it. When someone is hypoglycemic and they're in a state of, what should you say with type 1 diabetes? That means there's a lack of glucose to the brain itself. But it's usually in times when someone could have insulinomia. But again, I'm thinking more like my type 1 patients who could have issues with their insulin as well, which could cause hypoglycemia to the brain. So yeah, so that's just insulinoma is just one way that hypoglycemia can happen there. Let's see. So clinical features is really based on insulin is here. So yeah, well, yeah. When I think of insulin, though, I think of insulinoma, I'm thinking more like just increased amounts of insulin. It could be due to, pancreatic cancer. I was thinking it was like a formation like a lipoma or, oh, no, sorry. Yeah, so it leads to hypoglycemia. So that's just an example of how that can happen. Okay. Clinical features, again, leading to reasons for cerebral ischemia. Really depends on, again, how long this is happening. Like if someone is like the example of the insulinoma. Again, I never think of insulinoma as being a tumor. I'm always thinking about it just hypoglycemia due to elevated insulin levels. And I'm not going to put that on your exam. It's just meant to be an example of how that happens. But in these cases, if someone has long-term uncontrolled type 1 diabetes, they're always hypoglycemic, right? Versus someone who has like just a new onset of anemia. That level of brain ischemia is going to be different depending on the magnitude of the disease process. So mild forms of that can cause, maybe some temporary confusion, cloudiness. But once a person, gets, let's say, their anemia up, they get a blood transfusion, they get maybe some orange juice, they become their glycemic levels go back to normal. That can actually resolve itself. Severe ischemia, again, is what we see normally relating to like necrosis. It can, if it's really extreme, especially like after a stroke, could lead to a vegetative state. But oftentimes we see these like moderate forms of ischemia in our patients, which they're still, functioning in some ways, but there's a lot of underlying pathophysiology that's happening there. It can then cause seizures. Sorry, Lauren, what, the hypoglycemia or the tumor?
Yeah, the hypoglycemia. I guess I was wondering if it was like the insulinomia.
Oh, normally what I see is coma. It leads to insulinoma, and what I've seen in the text is mostly trying to think if it could probably lead to a seizure depending on the electrolyte changes.
My
But
dad, type 1. My dad's a type 1 diabetic and has had like multiple seizures from hypoglycemia. So I didn't know if that's what you were talking about.
Has he ever gone into a coma?
No.
I wonder what distinguishes a seizure versus like pathophysiology versus a coma. The patients I have that present with seizures, there's usually some other underlying, like some sort of electrolyte change because of the hypoglycemia. I'm curious, did they take your dad's electrolytes, or was there some like other?
It hasn't happened in a couple years, but
Good.
I'm not sure.
Good question. I mean, seizures happen for so many different reasons, but I would not surprised there's usually a connection there. Yeah, Gabrielle, exactly. I'm thinking like sodium, right? I'm thinking like there must be some change in potassium sodium levels because of the insulin change that causes a seizure. That's what I was thinking. So in cases where there's moderate global ischemia, that could lead to what's called changes or infarcts in watershed areas, which are watershed areas in the brain are areas, and I'll show you a picture, in between arteries that are highly like vascularized. So there's a lot of blood motion there. And if there's ischemia and this leads to infarcts, that's usually the areas where it happens, where normally there would be high vasculature. So normally when there's infarctions there, because it's normally highly perfused, you then see a lot of different changes to those areas of the brain. So again, watershed areas are normally high vascular areas, but again, in times of infarction, those are the areas that are more vulnerable to infarction. So you might see, again, this is more of anatomical, pyramidal neurons, the cerebral cortex, or you might see the neurons change in the hippocampus, like the temporal lobes. That affects more like long-term memory, or the Purkinje layers of the cerebellum that more affects the sensory perception with motor control. So depending on where that infarction is happening, any of these three areas, again, cerebral cortex, the hippocampus, or the cerebellum, can be affected by that infarction. And that's really, again, moderate. That's considered more of a moderate presentation. Let's a question. Trying to think, is there enough on this slide to give you like a decent, I think a decent question. Let me go to the next slide and see how I'd phrase that. Oh, this again is more of just anatomy, knowing the different layers, more related to, I'm not gonna, so we're gonna get into layers of the, trying to think of the term, cerebral cortex. For the purpose of the exam, you don't need to memorize this. It's really meant to say the placement of each of the cells and its functioning, like the dendrites and so forth. We're going to get more into that when we get into demyelination disorders, but you do not have to memorize this. Here. So if I were to ask, like in asking, I think a test question, making a distinction between like ischemic stroke versus hemorrhagic strokes, the presentation of that. To give an example here, I'm not going to test on these different types of neurons, hippocampus down here. I think it's just too broad to ask a question about any of these up here causing ischemia. So let me get through this slide and then I'll come up with, I think, a better type of possible
You could
question.
ask a question about like causes of ischemia.
Different what?
Like causes of ischemia, and we
Yeah.
have to like, I don't know. These are all causes of global ischemia except.
Oh, yeah, you could ask a question like that. I think that'd be so, yeah, you could. I mean, but so broad because I think a lot of things can cause ischemia that you might even realize. The patient experiences MI, etc. What type of ischemia is expected? Yeah. Oh, okay. You could, well, what type of ischemia? That you could do that maybe on this slide. Yeah, you could do that. That's a good question, Matthew. You guys put this also on the shared doc so that we could, I could probably pull some questions from there. So in regards to an ischemic stroke, you guys know the distinction between a TIA and a stroke, right? So the TIA, which is a lack of blood flow to an area of the brain causing a form of ischemia, normally the symptoms of that last less than 24 hours, we say like 12 hours or so, that's considered a TIA, which is a transient ischemic attack. Versus if someone had a true, what we call a stroke, that's part where the brain is not getting blood, right? There's a form of ischemia happening there, where the neurological deficits and the symptoms last more than 24 hours. And we subdivide that into different types of strokes. So there's thrombotic, embolic, and Lucarnar. So the thrombotic and I think embolic are the ones that we're most familiar with. So if you think about a thrombus, right? So like a clot, it ruptures usually from plaque development. And this is usually plaque development, usually when there's like, I'm going to show you what's called the circle of Willis, which is like a pathway of blood flow of the arteries. Normally within the carotid, there's like a bifurcation where they sort of separates, and you just can have plaque development there at that branch. Plaque developments can break off as plaque and develop into a thrombotic stroke. So that'd be an example of that. And I put here again that bifurcation, and I'll show you a picture of that circle of Willis. On radiology, it shows as a pale infarct. In the periphery, there's I'll show you a picture of it. You have the cortex, you actually could see an area of paleness under CT scan. In an embolic stroke, this is something that's actual movement of the clot itself. Normally, let's say someone's an AFib. So on the left side of the heart, they throw a clot, it goes up, usually through the middle cerebral artery, leads to an embolic stroke. And again, this could also lead to a hemorrhagic infarct. Same thing, there's a periphery of the cortex there, which I'm going to show you within the circle of Willis. A person is susceptible to a hemorrhagic infarct within that space. And then a Lucarnar stroke is usually due to, we've talked about this many times, a hyaline atherosclerosis. So if you guys remember that, so diabetes, hypertension, right? That poor vascular flow, changes in hypertension due to proteins embedding within the vessel, causing the vessel to be weak. These usually happen like at more like smaller vessels within the brain. So we call them lenticulostriae vessels. And again, that's usually more within the brain tissue. So the person ends up with these small cystic areas of infarction, which can be difficult to initially recognize. But these internal capsules of infarction then leads to other problems later, like pure motor strokes, or if it's leading to changes in the thalamus, it could be just a sensory stroke. And that, again, is very specific to Lucarnar strokes, which, again, are very small cystic areas of infarction within the brain. So at this point, Loretta, I think you could use this to maybe create a better exam question. So a patient with a history of hypertension is coming in with sensory changes. The nurse would expect maybe what type of infarction, or I wouldn't say what type of ischemic stroke, I think that's too, or what type of ischemia, or what caused this ischemia. And the answer could be, it could be a Locarnar stroke. It could be, you could say that it's related to, I wouldn't say striae vessels, or it could be due to hyaline atherosclerosis. I think that'd be a good answer choice. So looking at it from that way, but making the distinction between, again, thrombotic, embolic, and the Locarnar strokes is important. Okay. Locarnar infarcts from increasing hyaline, exactly. And keeping in mind that hyaline atherosclerosis comes because of these chronic disease processes like diabetes, like hypertension, which then leads to these very small cystic areas of infarction. I think the word Locarno comes from the word lake. So I'll show you that. Do I have a picture of that? Yeah, here. So this is actually what you end up seeing. So if you remember that first picture I showed a few slides back of the ventricles, you guys could actually see that here, your third and fourth ventricle space. These areas here would be an example of like the Locarnar stroke. So there's an area, it's an infarction, and it leads to like this ischemia and necrosis, but it's very small areas like this pinpointed within the brain itself, leading then to sensory deficits. Okay, so I'm going to show you the next picture. Actually, I'm going to go back. This is the circle of Willis. So this circle literally encompasses this area here. So the circle is literally going around this area. So if you have a lack of blood flow, again, within, like I mentioned, that watershed area, it really affects, you know, this area around the circle of Willis, then that could lead to Locarnar strokes. So again, you can see the picture, it says circle of Willis. Again, that's that circle here of blood flow throughout, really infusing, you know, the brain tissue. And I'm going to come back to this picture because I'm going to talk about like weaknesses and aneurysms that can develop here. But if you look here, how you have the vessel, and you sort of have like these veins that come off, you could have these striae vessels here that could be infarcted coming off of the circle of Willis, leading again to those Locarnar type of strokes. Okay. And
It's
then
kind
here,
of cool, like seeing that picture, because I read the scan sometimes for like the stroke patients, and it'll say like ACOM or PCOM, and I'm like, I know it's a vessel. I don't know where it is.
oh,
in the
well, then
brain,
here you
but
go. This is exactly what they're talking
yeah, now it
Awesome.
makes more sense.
Love it. Good. I love when things are like aha moments. So this is an example of the CT scan I was mentioning about peripheral infarctions. So here, peripheral of the cortex, right? So, but looking at this, you really honestly wouldn't know necessarily if it's due to a clot or a hemorrhage just by this picture itself. But you could obviously see here, there's like a hyperpigmentation showing an infarction, and again, of the peripheral cortex. So that you could see on the reading. And this again is an example of a Locarnar stroke, very small area, right within the circle of Willis, right below the ventricle space. But that's a compromised area, then leading to either sensory or motor changes. Can you explain the difference between the anticipated symptoms of Locarnar versus embolic versus anticipated? Oh, the symptoms? Yeah, let me. So it's hard to differentiate based on symptoms. It's more so etiology is the way I would think about the strokes. So the stroke is due to plaque rupture development leading to a clot, then I think about it being thrombotic. If it's more like a clot movement, then I'm thinking it's embolic. And if it's due to vessel damage, then I think it's more like a Locarnar. So to answer your question, Matthew, I wouldn't think of it like how do symptoms differ between the different types of strokes. I would think of like what caused it is how you name the stroke. So, the reason for that is because the actual placement. So if you work in neuro, the type, what caused the stroke can actually tell you where, or you sort of connect where the stroke then is. Because if it's a thrombotic stroke, you normally, again, would see it close to the circle of Willis. Usually there's usually a bifurcation there where plaque development had occurred. Versus an embolic stroke, I'm thinking more like middle cerebral artery, any connection, like someone who had AFib, where you're having that clot go up through the carotids. That's more so related to an embolic
Would
stroke.
you ask a question like that? Would that be a question?
Yeah, I would more so lead to the etiology. Like a patient comes in with a history of maybe something like that. Versus if I ask you, a patient comes in with like hemiparesis or right-sided facial droop, there's really no way to tell based on presentation which type of stroke you're dealing with just based off that. That wouldn't be fair.
Sure. Thank you.
Yeah, definitely. Okay. But yeah, good question. Because yeah, the presentation on someone with a stroke, it's hard to determine exactly necessarily where or what type of stroke caused that necessarily.
Yeah, because usually in the ER, I see them, at least they're not as concerned about like lacunar
No,
stroke, to be honest with you.
Lucarna strokes are also very like, when I have seen it, it's almost like you don't recognize it was a stroke initially because the person might have just lost some minor motor functioning or some minor sensory functioning, and then you send them over to neuro, and then they do further testing, and then they do a CT scan, and then you find out it's a Lucarna stroke. It's not as obvious versus.
Because I was doing practice questions and it was like saying that it's more, I don't know what it meant, but it was saying it was more sensory based deficit for the.
Lucarna strokes.
Yeah, that's the only reason why I asked. I wasn't sure.
Yeah, like Lucarna strokes are more about like changes in like feeling and touch, and it could even affect though like hearing and vision and so forth, versus thrombotic embolic is more like actual like textbook stroke, like the side of the facial droop, the hemiparesis, all of that.
Gotcha. Thank you.
Good question. I had a good test question that came to my head. What was it? Oh man, it was gonna be good too. Now I forgot. Oh, how we previously talked about changes in perception and spinal lesions. Maybe a patient comes in with like a sensory deficit, and you have to distinguish between a Lucarnar stroke and a spinal lesion. Maybe the presentation between the two and how you would differ between the two. That could be a good test question. Okay, just thinking. Gabrielle, is that a glass of wine? No?
No, but I'm gonna need it after
I
that.
was like, if you need that to get through the class, you're very much welcome to.
It's too early. You can
No,
only
this
drink
is-
white wine.
It's palm. It's palm juice.
Oh, okay. Also, she's having a glass of cab. Okay, no, you're fine. I'm joking. I would maybe have a shot. Okay, here we go. So we talked about infarctions, right, which actually is a lack of blood flow. Then you want to distinguish between hemorrhaging, which is actually bleeding out, right? So in this case, make sure you make a distinction between this and hematomas, which also I think could be sort of like confusing. Hematomas are actually a pooling of blood in certain areas, like a subdural, like a very specific part of the brain, which then changes the anatomy and causes herniation, versus in hemorrhaging, intracranial and subarachnoid hemorrhaging, the bleeding is profusely into the brain parenchyma, which then changes clinical manifestations, okay? And again, the etiology is different, of course. So in intracranial hemorrhaging, it's due to usually the rupture of again, I always say these names and you guys can correct me, the cricoid Barkside microaneurysms, which the term itself I don't really care about, but the term microaneurysms is so important because there's areas of the brain that are more susceptible to that, which I want you to be familiar with. So the lenticular striate vessels I mentioned when we talked about the Lucarnar strokes, there are areas within those vessels that are more prone to aneurysms because of its anatomical differences, which I'm going to talk about. If someone is suffering from hypertension, that can make them more susceptible to an aneurysm, which of course makes them susceptible to an intracranial hemorrhage. The basal ganglia is a most common site for these aneurysms to take place. And these people, when they come in, present with headache, nausea, vomiting, and it can lead to a coma if not caught in time. So what I mean by that, which I think I had a picture, is these microaneurysms within those leukostriate vessels, looking closer to that circle of Willis. So you see here these different aneurysms. This picture sort of shows, right, where these different aneurysms can take place. The reason for that is because these leukostriate vessels, the areas where the aneurysm is, they actually are missing. If you remember from our cardiovascular lecture, our vessels have 3 layers. A lot of these areas within the circle of Willis are missing what's called the media layer, if you guys remember that. So because that media layer is missing, that just makes these leukostriate vessels more prone to aneurysm development. So I wanted to share that. And this picture really just says, like, percentage-wise where aneurysms develop. More so here, the anterior communicating anterior aneurysm, which is really that front part lobe of the brain. Really affecting, again, causing, well, you could see all kinds like personality changes and memory loss and motor functioning. But again, just showing where different types of aneurysms can take place here. So that's really, again, leading to the term here, microaneurysms of the lenticular striae vessels. Now, compared to subarachnoid hemorrhaging, this is again leading to bleeding in the subarachnoid space. Think about anatomically where that is. You have the arachnoid layer. These are people who present, if you ever hear a patient says, like, this is the worst headache of my life. There is some overlap with like how someone might present with like with meningitis, because these people can also have nuchal rigidity. So something else I think would be a good question if a patient presents with nuchal rigidity, distinguishing between a subarachnoid hemorrhage versus meningitis. But these people, again, specifically have what they say, like, the worst headache of my life. If you were to do a lumbar puncture because of the bleed, you're going to see that xenochromia, which is, again, that blood breakdown to bilirubin. Is there a physiologic benefit for those vessels to lack media? So I always think of that too, Lauren, like, why I believe in God and creation, all of that, or like, what would be the benefit, or if you believe in evolution, like, why would be the benefit of not having media within those layers? That's what you're referring to. And there must be some sort of need. I'm thinking it has to do with maybe like blood perfusion, like you said, like diffusing thing, right? Like that's what I think, the same thing. There has to be a reason why there's no media in that space. So yep, I think the same thing. In a subarachnoid hemorrhage, again, you're going to see those changes within the cerebrospinal fluid. If there is a bleed there, frequently 85%, it's due to those rupture of a Berry aneurysm. So I'm going to again show you on that next slide again where that is. Other causes could be an arterial venous malformation. I think the story Gabrielle told us about the nurse who was walking the dog, she was on like maybe an anticoagulant. We had, won't tell you which hospital, patient fell in the bathroom, hit their head on the sink. They were the reason they were being they were on a heparin drip. They bled right out, right? So that makes us someone more susceptible to this. Berry aneurysms, again, there's that thin-walled outpouching, which is what an aneurysm is, because of that lack of that media layer. Makes a person more at risk for aneurysm development. And again, you really want to consider other clinical issues going on that makes a person more susceptible, like being on an anticoagulant, like hypertension, especially for an intracranial hemorrhage. And again, if you think about the picture I just showed you, I'll go back to it, was most frequently around the anterior circle of the Willis branch. And again, due to the lack of media and that area is considered the anterior communicating artery. It is also associated with Marfan syndrome. If you guys, I think we've talked about this a few weeks ago. People with Marfan syndrome usually have some sort of connective tissue disorder, which makes their connective tissue weaker. They're more prone to outpouching. And people in autosomal dominant polycystic kidney, that's also part of this exam, are then also prone to subarachnoid hemorrhage, which again, was something I think would be a good exam question. We have seen a lot of hypertensive bleeds. These need to get, I know, and it bothers me so much. They come into my office like 180/90, and I hate them because some of them are nurses. And I'm like, seriously, like you should know better. And they're like, oh, I'll just take my blood pressure meds when I get home. And I'm like, why is that okay? I had a patient come in. She's not a nurse, but she's like, oh yeah, I haven't had my Norvasc in a few days. And I'm like, why not? She's like, I don't know if my PCP refilled it. And we called, I had like call the pharmacy now. And she called, they're like, oh yeah, it's here for you to pick up. She's like, okay, I'll go pick it up. I'm like, why would you wait till you're 210 over like 100 to pick up your Norvasc? Like, her excuses were just, oh yeah, I just haven't had time to pick it up yet. I'm like,
I've seen
okay.
people get PEs because they can't, issues with insurance for anticoagulants as well. Like
Oh,
local
that's horrible, right?
stuff,
Like,
or or stroke from it.
just
I
because
think
they're
there's like there are those cases where, you know, there's insurance issues and those are really unfortunate, but in general, I think people are just like not going to the doctors. They might not even be aware that their blood pressure is high, or people are weird about taking medication. So like I took care of this like 65-year-old the other day who's definitely going to be like essentially in a vegetative state for the rest of her life because she had a hypertensive bleed, and like her children were there who are my age, and it's just
oh, that's sad.
unfortunate because it's preventable and people just need to manage their health better and they don't take it serious.
I could be on a whole soapbox. You're right. Because, well, my main thing is people are like, well, I don't feel anything. I feel fine. I'm like, that's why it's called the silent killer. Like, I'm always like, I'm like, you're not supposed, you won't feel anything until you actually have the stroke. Like, I go off on my patients. I'm like, how hard is it? Like, take a pill. I'm like, oh, I'll just go see my doctor tomorrow. Because I'm not a primary, right? I see them for endocrine issues, diabetes, weight loss. And they're like, oh, like, they're like, oh, never mind. I'll go see my primary tomorrow. And I'm like, I'm prescribing this now. Go like I literally have a Walgreens next door, and I'm like, we're gonna go to Walgreens right now and pick up your blood pressure medication because I don't trust you. Matthew, what were you saying about you saying like insurance is not paying for it? Well, that's a whole nother argument to have, which is just ridiculous on its own. Is that what you're referring to, insurance coverage?
Oh yeah, no, like I don't know about blood pressure medicine, but for anticoagulants, I know there's some people have an issue with getting the anticoagulants because of insurance.
Oh, and
Like
also
one
even if you
Eliquis
have
pill was like
insurance.
$60 or something.
Well,
60.
take my uncle, for instance.
We used to have to count Eliquis where I used to work. We had to count it.
You have
It
to
was so
count it
expensive.
out.
We had to count it out as if it was a narcotic.
So my uncle is on, it's Eliquis, right? It's like really expensive. And so I got him Medicare Part D, which I can go into Medicare, Medicaid issues. That's a whole nother thing. And even with Medicare Part D, I'm still paying. My mom passed away like 10 years ago, and this is her younger brother. So I feel the need to like help, which I'm probably like doing too much, but I pay the difference of it. And it still comes out to like hundreds of dollars, like for 90-day bottles. So I'm thinking like, if someone couldn't afford this, are they just going to go without their Eliquis? Like, it doesn't make, and that's with insurance coverage. So
My mom was on warfarin for I don't even know how many years because she had PEs twice. And she tried to switch to either Eliquis or Xarelto or whatever. And it took so many months because it was just because of insurance.
yeah, not interested. So Corey, they actually tried to put I think he got on Xarelto, but that still was expensive. Like, and then if you guys are familiar with Medicare, which I think you'll learn later on in your program, there's something called gap coverage. Are you guys familiar with gap coverage? So that means in the beginning of the year, you get like 100% covered, or like, and then as the year progresses, depending on how much you've spent, by the middle of the year, you get like 50% coverage. And then always by like October, November, I'm paying for like 100% of the medication. They have copay programs that yeah, I've tried to apply for those. Also can be, so they have, I think, there's one, the Good RX plan, I think has been helpful. So yeah. Oh, Eliquis has coupons. I'm gonna look into that. So anyway, I can go on a whole about this, but we're almost done. So let me get through demyelinating disorders. Who gets from environment from blood pressure? I'm just reading what you wrote, Myra. That's just, yeah, just patients being resistant. What can you do sometimes? You're just not, interested in helping. Loretta, is Mark Cuban, is that is he working with Amazon? Is that I've heard Amazon's now doing pharmaceuticals, or is that something?
I'm not sure. I think if you just Google Mark Cuban pharmacy, like I tell patients to get their medication from there sometimes,
No?
because they could get like certain medications for like, $10, when it would
Oh,
be like really expensive
I'm
otherwise.
gonna look into that. Thank you. Okay, what, every time I see Loretta's, I'm thinking I need to give like an example test question. Okay. Let's go through this. I think pretty straightforward, demyelinating disorders. A little background, if you guys remember the myelin sheaths, they cover and insulate the axons. So if it's myelinating the central nervous system, we call those oligodendrocytes. I don't know why I can always say that, but I can't say other simple neuro words. And then if it's peripheral nervous system, Schwann cells myelinate the peripheral nervous system. And at any point, any of these areas can be demyelinated, meaning that that actual covering comes off, the myelin sheets, but you still have the axons in place. If you guys remember, I want to back up a little. The myelin sheets is what causes like quick communication. You guys remember that between your brain and your periphery and your central nervous system. So it's what allows that quick, fast communication. The fact that that gets demyelinated slows that transmission, right? Exactly, it's like insulation for electricity. I think the same, that's the picture I have in my mind. The axon itself is preserved so that the wire, I think, is there, but the cushion around it is what's missing to cause that fast connectivity. So an autoimmune disorder where there's this demyelination happening is multiple sclerosis. It's specifically an autoimmune destruction of the central nervous myelin and oligodendrocytes. It's considered the most common in young adults between ages 20 to 30. My dental hygienist was diagnosed with that. So I think about multiple sclerosis, I think of her. Most commonly seen in women. And they always say also it's most commonly seen away from the equator, so like colder areas, which I find interesting. It presents with these relapses. So someone could be like really like in this state of exacerbation and then they go back into remission. And that's really just about where the lesions are occurring. And again, they have like these times again, exacerbation and then times of remission. Oh, 18, that's rough. So yeah, and sometimes I've heard like, people getting diagnosed younger. So the list here really is just how it can present clinically. And the term for it is on the left, and the area that's being actually anatomically affected is in the parentheses. So if someone's having blurred vision in one eye, that's because the demyelination is affecting the optic nerve. If someone's experiencing like vertigo, almost like there's a type of speech called scan that says it's like when someone has alcohol, like they can't really speak clearly. It's because there's a demyelination of the brain stem. I got into this just to show you an example. There's a term intranuclear ophthalmoplegia, which again is plasia meaning lack of movement. This is particular to the eye. The demyelination can actually occur at the medial longitudinal fasciculus, which is, I'll show you that in the brain, which then actually causes a prevention of eye movements. In multiple sclerosis, if there is a unilateral or a hemiparesis occurring or a lack of sensation on one side, there could be a demyelination specifically of the white matter. And I'm going to talk about differences between white and gray matter. I'll mention that real quick. And then the lower extremity loss of sensation or weakness affecting more of the spinal cord. We have people who have multiple sclerosis and demyelination affecting the autonomic nervous system, which then affects their bowel, bladder, and then sexual dysfunction. So depending on where the demyelination is occurring, again, any of these presentations can develop. Brain development is more common in... Sorry, Loretta, what's NMO?
Neuromyelitis optica. It's like an MS mimic.
Oh, that's interesting. Do you work in neuro?
Yeah, this is my specialty actually.
Oh, so okay, you give the lecture then, because I'm tired of talking.
Okay.
That'd be great. Brain stem involvement is more common. So if you were to see like this clinical manifestation, it could be, instead of multiple sclerosis, could be NMO.
Right, yeah, it's more common in NMO than MS.
Oh, that's interesting. Regarding the bullet points, yes. So actually I could, well, I was gonna joke and be like, we could use that, be like, a patient presents with, you know, possible diagnosis of multiple sclerosis, the nurse would expect, but no, I can't really incorporate the NMO thing. Not everyone knows what that is. So I think a way a question would present in this would be, I don't normally relate, again, the specific anatomy to the clinical manifestation. Maybe it would be something, because if a patient presents with hemiparesis, for instance, I'm always thinking like, how would I want you guys to think this through? How do you know that's multiple sclerosis versus a stroke, right? So, maybe something like a 20-year-old female comes in, right? So maybe you could just make a 20-year-old female comes in complaining of hemiparesis, maybe slowly worsening hemiparesis of her right extremity. The nurse would expect to find what on CT scan, and it would be something that says demyelination. I don't think I would be very specific in regards to where. I would never say like demyelination here, demyelination there. Like that would be ridiculous. But some sort of, the answers would probably be like, with maybe a bleed would be an option choice, and then maybe some sort of vessel change, aneurysm, and then a demyelination. And you'd have to know like that's a demyelination. If you see hemiparesis in a 20-year-old with nothing else going on, I'm thinking multiple sclerosis, something like that.
If there's going to be like a question kind of similar to what you just said, in addition to hemiparesis, can you give us like another symptom so
Yeah,
we're
there'd have
not
to be something else, right? Like,
I would say
yeah,
the classic sign for MS
like the
is
bowel,
optic
bladder, and
neuritis.
like or bowel and bladder dysfunction or something, like something to separate, because hemiparesis is like there could
right,
be
it
so
could be
many.
anything.
Yeah.
I agree with you. So yeah, and normally again, that's where we get to the wordiness of the stem, but it'll be more than just hemiparesis. It'll be something else to help. So there'll be young, female, hemiparesis, something else. Loretta, you were saying what is the most common?
The most common symptom is optic neuritis, is where it's like temporary blindness in one of the eyes, or like a grade scale vision.
So yeah, actually, trying to think now who this person was to me, but yeah, they lost vision for like, I forgot, it was like a day. They went to the emergency. They didn't initially go to the emergency room. They went to an eye doctor, and I think the eye doctor sent them to the hospital, something like that. And that's how they were diagnosed with MS. And then that was like the first symptom ever was just the loss of that vision. So MRI reveals plaques. So what you would actually see are areas of white matter, demyelination. You could do the lumbar puncture. I'm curious, Loretta, what's their normal method for diagnosing?
So typically we do brain MRIs, and it depends on the lesions. The lesions are usually round, and they have to be like, you have to have more than one lesion, and it has to be like dissemination of time and space, meaning like you have multiple lesions, and one might be like lit up with IV contrast, and the others would be like not lit up. They would be like kind of darker, which would mean like they occurred previously. So that would be your time, and then the different locations would be your space.
Oh,
And then
interesting.
if that doesn't give you, like if it's not in the right areas, then or you don't have like symptoms that might match where the lesions are, then the doctors are like, all right, let's do an LP and see if they have any bands.
Okay, so actually that's exactly what I wrote here. So in the LP, you would normally see increased lymphocytes, increased immunoglobulins, and just like Loretta said, you're going to see these immunoglobulin G bands. And again, on electrophoresis, you're going to see this high resolution of that. The myelin basic protein, I'm not as familiar. That was more like textbook. Do you see that, Loretta?
No, but what we would
Okay.
do is a blood test to rule out like the MS mimics, and then you could also test. They have a new test that's demyelinating disease panel.
Okay.
So we would make sure to do that also.
Oh, that's interesting. So I think this would be also another really good question, because if I ask you about diagnosing based on lumbar puncture and CSF, and I'd say increased lymphocytes, you have to keep in mind like multiple sclerosis does fall into that, versus when we talked about meningitis, if you guys remember that, the differences between bacterial, fungal, and viral. So again, just putting some hints out there, like how to think of these things. So as you're reading through, if you see like similarities in different processes, like keeping that in mind. Because again, as a clinician, when patients present this way, you have to realize like all the things that something could be, and then how to sort of narrow that down. So I think that's interesting. Okay. So this is an example of that vision change I was referring to. So let me go back so you can see here. This intranuclear ophthalmoplegia, which again is the demyelination that could happen at the medial longitudinal facials, which again is really here, that MLF is here is that cross section where demyelination can occur. And one of the tests you could do, and again, this isn't as necessarily as common, if the person's looking forward, normal, they look right, depending on where the demyelination is occurring, that could be normal. But what you notice if they look left is this nystagmus that occurs on the left eye, and then the right eye actually has this sort of like inability to move because of that demyelination. And it really is affecting the sixth and I think the third intracranial nerve. So again, that's just that the demyelination that's happening here. Oh yeah, it says it here. These are the cranial nerves, cranial nerve 3 and what they control, cranial nerve 6. And then how that connects, see how the green here is connecting and crosses over, and how that affects the movement of like the right eye versus the left eye. So just an example of that. Okay. And then just, I think we're going to end with this, right? Dementia and degenerative disorders. So dementia in itself, degenerative disorders, I mentioned the differences in gray and white matter. So loss of neurons within the gray matter is normally what we think about in regards to, when you think about gray matter, when you think about like signal origination, like that's where when your brain's functioning, that original communication comes from your gray matter, and it's the white matter that really works in the transmission of that sense. So normally in times of dementia and degenerative disorders, there's usually an accumulation of proteins which damages the neurons that prevents the gray matter either from working properly or the white matter for working properly. If there's a degeneration of the cortex itself, that leads more so to dementia. And if there's a degeneration of the brainstem and the basal ganglia, and that's sort of like this picture I was showing here, that more so leads to changes in movement disorders. And again, thinking about where that starts in the gray matter, moving on to white matter, this again just sort of gives you like a little background, just as a refresher for neuro. And again, cortex, more so dementia, brainstem, basal ganglia, you're thinking more like movement disorders. So in Alzheimer's disease, you're thinking that's more cortex related. There's its most common cause of dementia is considered Alzheimer's disease. It's usually very slow onset of memory loss, usually beginning with like people not remembering things that happened more recently, and then progressing to things like more long-term, things that happened a long time ago. And there's this as time goes on, there's this progressive just deorientation to everything around them. Loss of eventually learned motor skills and language, changes in behavior. I've seen personality changes. Patients can eventually become mute, bedridden, and usually the cause of death because of that being bedridden and movement is infection. Early on in the disease, you don't normally see focal neurologic deficits. Again, normally it starts off as more of a memory loss issue, and then later on progresses to being mutes and movement and so forth. There are some genetic connections, but usually, let me say like 95% of the cases is sporadic. It is seen, and your chances are higher as you get older, so being seen in the elderly. The risk does increase with age, and the thought is that it doubles every 5 years after the age of 60. But we've seen cases like there's early onsets of Alzheimer's disease. So again, the genetic connection. These are just mutations in the genes that can cause someone with family history of Alzheimer's being then more susceptible because of these mutations. But Down syndrome has also been connected to early onset of Alzheimer's, and that usually occurs by the age of 40. And the reason for that, well, I'll tell you directly. Do you know what's the other name for Down syndrome? Anyone know? Perfect. Thank you guys, Myra and Naomi. Trisomy 21. And the reason I ask is that's how I always remember that early onset dementia, early onset Alzheimer's disease and Down syndrome is because of trisomy 21. So trisomy 21 literally means, right, tri meaning 3. There's 3 chromosomes of the 21 position. So that third output causes the person to be more susceptible to Alzheimer's. So that's why I was thinking about trisomy 21. So that third chromosome makes a person more susceptible. And the reason for that, and that goes into this picture here, is because of what's something called APPs. So that third chromosome, and in any Alzheimer's disease, this person, what we find, has more APP, which amyloid precursor proteins. These APP molecules, which everyone has, when it's gets older and it starts changing, it actually can, it's improperly discarded by the body. It changes into plaque development at the cortex, embeds into the cortex, and then causes Alzheimer's disease and turns into what's called beta amyloid plaque. So that's why people who have more APP development are then highly more susceptible to Alzheimer's disease because of this beta amyloid plaque development on the cortex. And that's what this picture is saying here. So again, anytime I think of Down syndrome, I think about trisomy 21 and that third chromosome putting out more APP and then leading to, again, this beta amyloid plaque development on the cortex. Okay. Getting into Parkinson's disease. So this is considered a degenerative loss of dopaminergic neurons. Specifically, this is at the substantia nigra of the basal ganglia. I think for Parkinson's, that's sort of understood to regards to placements. Again, I try not to get into as much of the anatomy, but understanding that it is a loss of dopaminergic neurons is important. The brain follows what's called the nigrostriatal pathway of the basal ganglia, and that's what uses dopamine to initiate movement, and that's what causes problems in movement within patients with Parkinson's disease. There's three different main pathways within the brain, which usually uses dopamine. Specifically, the nigrostriatal pathway is more like a circuit of communication within the brain, which initiates like voluntary movements, body positioning, and posture. And that's what is changed because of the dopamine degeneration in Parkinson's disease. So it is considered a common disorder related to aging. It's seen in 2% of older adults. I don't know if I told this group back in January. So last year I was, of course, I'm an NP and you guys are nurses, so you're always assessing your loved ones. And I told my dad, I was like, you look like you have like a Parkinsonian walk. He's like, that's not funny. My dad's also a nurse practitioner. And I had him evaluated last fall, and he just got diagnosed with Parkinson's, which I'll tell you, I'm a little questionable about the diagnosis. But so yeah, recently diagnosed, and we're going through like PT and OT and medications and everything right now. The etiology for Parkinson's is really considered unknown. Rare cases were connected before to it's called an MPTP exposure, which again, I don't know if that's really considered a connection now to Parkinson's, but the clinical presentation is the TRAP. So tremor, rigidity, akinesia or bradykinesia, and postural instability. So these people have that pill rolling tremor, but if they're moving, it's sort of, you don't see that, like it goes away. This cogwheel rigidity of the extremities, very slow voluntary movements, faces become more expressionless, shuffling gaits. So that's sort of like the textbook presentation of Parkinson's. I thought I saw something in the chat, but I think it got deleted. Okay. If you were to do histology, like looking at the person's actually brain tissue, there's a loss of pigmented neurons, again, at that substantia nigra, and round eosinophilic inclusions, which we call these are Lewy bodies in affected neurons. So you could see Lewy bodies again within, like later on, if you were to do histology of Parkinson's. But Parkinson itself is really considered more of like has to do with like movements of the person. So again, you have that slowing of the movement, instability in the gait, shuffling gait, tremors, and so forth. The thought of dementia is really not part of Parkinson's. I want to make sure you take that away from this lecture because people tend to think of them being simultaneous and they're not. Early onset dementia is usually suggested of Lewy body dementia, so not so much related to Parkinson's. Later on, a person with Parkinson's can develop dementia, and usually it does progress to the point of dementia, but does not start there. If a person is presenting with dementia hallucinations, with those Parkinsonian like trap features, the thought is that they probably have Lewy body dementia instead of Parkinson's. And the reason I actually brought up my dad was because I'm actually thinking maybe it's more Lewy body because he like forgot how to get home the other day, like dealing with some of these things. He's in Florida. So I'm actually in the process right now of we're thinking of renovating the basement to have him come up here just because I'm an only child and I need, there's no one really there to watch him. So eventually, he's gonna have to come up here. The problem with Lewy body dementia is you can't really, it's not diagnosed except with histology, which you really can't do until you do like an autopsy. So again, presentation is important. So you want to make sure you see the trap features and really it's that dopamine changes for Parkinson's versus in dementia, you're going to see if it's Alzheimer's, you're going to see more of that beta amyloid plaque development. And in Lewy body, again, you don't see that unless you have, you're going to see the dementia signs, but then you're really on an autopsy. So this is like just the pathway, I think is what I was showing here, the nigral dopamine pathway, which shows a connection with the basal ganglia. And there's other dopamine pathways here. And again, when we speak about Parkinson's, we're thinking more of that connection with the voluntary movement and so forth. This is just a picture of Lewy body and what that looks like on histology, and that build up within the cortex of the brain. Okay. A lot of good talking and conversation and some sad, well, we're nurses, that's what we see, I think. We're going to end with Huntington's disease, which again, I don't know if you've seen this. Loretta, because you work in neuro, do you see Huntington's or is that not part of your scope?
I haven't really seen it.
I'm sure
And
that
yeah.
how common it is. I mean, in my years of practice, not so often, which I probably said maybe it's a good thing. Maybe it's not as common. So in Huntington's disease, you have this degeneration of what's called the GABAergic neurons. So if you think about GABA, if you guys remember GABAergic, so GABA really slows movement down. So if you have a degeneration of that movement, these patients then have this inability to slow movement and they end up with almost like what's called a fire action, like repetitive movements, which we call chorea, if you guys know that term chorea. And this happens at the caudate nucleus of the basal ganglia. And again, there's this degeneration that happens of the neurons at that site, which then causes, again, these like sporadic movements. It is an autosomal dominant disorder. It affects chromosome 4. What's happening is, if you guys remember your trinucleotide repeats, so CAG, they end up in Huntington's disease. This gene causes these longer expanded repeats. So you have like, let's say you have 8 rounds of CAG, or like the people with Huntington's disease would have like 20, 40, 80 rounds of this. And those trinucleotide repeats is what's causing, you end up seeing them, this changes then with this GABAergic neurons causing Huntington's disease. This bullet here, further expansion of repeats during spermatogenesis leads to anticipation. What that means is the further expansion of those CAG repeats. So spermatogenesis, the creation of sperm. So like the next generation, for instance, that next generation will have longer repeats of that CAG line. And that leads to anticipation, meaning that the next generation, if someone gives birth to someone with Huntington's disease, will then usually end up with Huntington's disease being diagnosed at a younger age. So spermatogenesis, again, means like that creation of the sperm, that development to the next generation causes longer CAG repeats, and then also causes the disease to present earlier in age. So that's really what that means. Again, because of the degeneration of the GABAergic neurons, they present with chorea. They can progress to dementia and depression. Average age is usually 40 years of onset. I have heard of one person committing suicide, and maybe that's, I don't know, in regards to prevalence of this, just because of how bad it gets at such an early age. There is a higher rate of suicide in this population. So yeah, that is sad. I'd hate to end the lecture. I think this is my last slide. So yeah, so Huntington's, I did put this as part of your outline. So look at that in your the exam 3 outline there. And again, I think I gave some hints in this, though, making distinctions between different types of diseases, especially when there's a lot of similarities in presentation. Knowing how to distinguish one disease process from another is important. A question on, so I think a patient comes in, let's say 56 years old, with, say 60 years old with signs of dementia. The nurse notices, so let me ask you, if I say the nurse notices beta amyloid plaque development, you would expect which type of diagnosis? Or which diagnosis would you expect?
Dementia.
Well, that's what type of dementia based on the lecture.
Alzheimer's.
Alzheimer's, right. The patient's brought in due to concerns of dementia and notices a degeneration of GABAergic neurons, right? Or I might say trinucleotide repeats. That would be if I say trinucleotide repeats.
Well, it would be Huntington.
It'd be Huntington's, and I'm actually on that slide. If I say a patient's coming in with signs of dementia, but also new onset dementia, as long as a new onset of shuffling gait and pill rolling tremors, the nurse would expect, and this is where it gets tricky, right? Because I'm thinking more Lewy body. If they're coming in with dementia early onset with Parkinsonian symptoms, I'm thinking Lewy body. If a patient comes in with, say, dopaminergic changes or lack of dopamine, I'm thinking what disease? I think Loretta put
Parkinson's.
Exactly. So I think from this section, Alzheimer's differing from Parkinson's, how it differs from Lewy body, and how that differs from like Huntington's disease. I'm thinking for multiple sclerosis, same thing, like just presentation and what you would either see on radiology or, but I think the young female normally would be the presentation there. Like Loretta said, maybe like an acute loss of vision in one eye, right? The nurse would expect, and of course put some other things in there like hemiparesis or some sort of loss of sensation. The answer would be multiple sclerosis. So yeah, I think that's mostly how it would present itself. Let me get out of here and actually just go, because I think Gab had a question about what was the question you had about celiac disease?
One of the practice question.
Yeah, let me go to that real quick. So for the purpose of our lecture,
Yeah, if you could open it.
I'm going to open it.
If you wouldn't
The
mind.
key difference between Alzheimer's, dementia, and Parkinson's is the Lewy bodies. So no. So in Alzheimer's disease, it starts off as dementia with a slow onset, slow progression. Parkinson's doesn't have dementia initially. It comes out later. If someone has dementia initially with Parkinson's-like symptoms, it's not Parkinson's, it's Lewy body dementia. Parkinson's does not come with dementia until later on in the disease progress. Is the Lewy body dementia part of Parkinson's or is it different? It's a different thing. I would think of it as two different things. You have Parkinson's with no dementia that can progress to have dementia later, or you could have Lewy body, which has Parkinson-like symptoms, right? Clinical presentation, but it's actually Lewy body dementia. Okay, let me see if I can find. Let's see. And I think someone wanted to do an exam review. What I'm going to, if I have time on Wednesday, because I am supposed to jump into a faculty meeting, we could do that. But I'm going to send out an email, maybe with the sign ups for Wednesday, and then we can, if a lot of people wanted to review, maybe we could do it at that time. But I do want to also meet people individually who have very specific concerns about just concerns about studying and so forth. Let me go to the question. So otherwise, you guys are free to go. I'm pulling up the question specifically that Gabrielle had regarding celiac. Let me look for that. Okay, so I really was looking at this slide here. And I have to pull up the question here. So this slide talks
Right,
about
I have the
celiac.
slides here too.
So
I guess
go ahead.
I understand, I guess, what you were trying to get at with the question regarding the iron, because it's with celiac, it's mainly in the duodenum. But I guess I just felt like it was a very like indirect way of asking about celiac when there's, like it could have been, looking at a scan or looking at symptoms. And I just felt like there was, I don't know. I hope that
And
the other exam questions are not similar to this, because I just feel like it's very roundabout.
Been vegetarian all her life, has a chronic history of heavy menses, secondary to uterine fibroid. The nurse would expect to see which lab on this patient. So I wanted
Like
you to
I just feel like
labs.
the question seems like it's talking about bleeding, and then I was like, okay, but celiac doesn't have to do with bleeding, so this is weird. And it really just came down to like an iron because it's located in the duodenum. Like I don't know.
So I think, I guess it's a good
I just hope, like I said,
conversation.
my concern was also that like I hope that most of the test questions aren't like this, because it's very, I don't know if like indirect is the right word, but I don't know.
Okay, so
It made me worried seeing that.
So I want you to think about how you think through tests. I mean, you got through the NCLEX, so obviously you're doing something right, but I think you're spending a lot of time trying to like interpret the STEM versus just figuring out what the answer is. So like the reason it's presented, and your questions are like this because this is how patients present, right? They come with heavy menses and they're vegetarian and they're smoking or they're drinking or whatever that is. And I want you to be able to take a patient's presentation and think like, what am I most concerned about in their labs? Like what, and I think you're spending more time like trying to connect, like, what does Benzi's got to do with celiac? It might have nothing to do with it, right? But I'm trying to put words in there that make you think like, what are my main concerns? If I know they have celiac, and that's what I do as a clinician, right? If someone comes in and they're 18 years old and they have heavy menses and they've got celiac disease, I'm concerned about anemia, right? That's what you should be taking. That's what I want to know that you took away from this, that as a clinician, I'm seeing celiac disease. I want to know, are you taking in extra iron pills? Are you, what is your hemoglobin level? That's what I want the takeaway from this to be. So it's a good conversation to have because I do wonder how, and part of what I do for undergrad is prepare them for the NCLEX. And part of that is how do you read, like how do you take a test? And part of it is, and I think that's what sometimes takes a long time, is people are reading through the STEM, trying to interpret the STEM when that's not right? The question is, and I guess if you were to make it simpler, which is one of the things I advise to do, is if you were to rephrase this question, the question is, which lab value is most concerning or expected with celiac disease? Like, that's really the question. So and then the reason I put menses in there though, is also again to connect the iron deficiency, which connects to the duodenum, and all of that. But it's the purpose of me making this was so that when a patient presents, you're understanding what are the key points to take away from that disease process.
But then going back to the material that we're presented, like it doesn't say anything about like iron deficiency is common in celiac patients. So then I understand what you're saying that, in preparing us to see patients, they're going to have all types of random things going on that might not be connected. But for
I
the
don't say it
purpose of,
here, but I
for the
said it in the
purpose,
heme lecture. In the heme lecture,
what?
we talked, I didn't say it in this slide, but in the heme lecture, we talked about, and I mentioned, I thought during lecture about the duodenum and iron absorption, right? So I might not
Right, but
clearly
this
write
test
it
isn't
as a
on,
bullet.
this test isn't on heme. This
Well,
test
all
is on
your exams
GI.
are over, if you haven't learned that now, like all your exams, right? There's cardiac things like that can be pulled into aortic stenosis, right? I could talk about connective tissue disorders. So I want to make sure that whoever is still on this and it's being recorded, all the material floods into every, I don't ever come into the exam and be like, we're only tested on pulm, this and heme, right? We could make it cumulative in nature, but your exams are always going to be overlapping. I mean, that's just the human body. So like, there are things we talk about like neutrophils from the first lecture, which I'll definitely ask you questions about neutrophils and lymphocytes on this exam, right?
I understand that. I guess my concern mainly is not just with this question, but the exam overall is that, and I don't want to speak on behalf of other people, but like other people have also expressed that they felt that the questions were unnecessarily difficult. And if the point of this question is to ask about celiac disease, then I don't know, I guess it's just weird to focus on iron malabsorption because it's not even mentioned in the slides.
I guess we're missing the mark here. Like if I want to tell you about celiac, I could say which of these diseases is an allergy to gluten, right? Like that's not what I'm trying to prepare. And as NYU graduates, it's not. And like there are certain levels of a nurse practitioner. There's certain levels of a master's degree, right? There's people that could be like, oh yeah, you have an iron deficiency because of your, whatever, because of your, whatever hemoglobin levels, right? There's these basic understandings. And you're right, if I wanted to ask about celiac, I could make it like, which one of these would you not eat with celiac disease? Like that's not the caliber.
Well, it also it doesn't need to be that simple, but I also think that I don't know. I'm not gonna beat a dead horse here. I just think that, I don't know, some of the questions are unnecessarily difficult.
So I'll say, when I took on this course a few years ago, I just took what they had and the level of the questions they were, and I just developed it from there. So I didn't start at this level initially, right? This course was developed before my time. I took the caliber that we were at, the expectation in regards to what you're expected to know for your boards, what you're expected to know to graduate from the course, what you're expected to know for advanced pharmacology, what you're expected to know for assessment, and right? So this course is meant to prepare you for all those other courses. It's not just to be like about celiac disease, right? It's supposed to prepare you for your boards, prepare you for assessment, prepare you for pharm. So these questions are framed in a way to do that. And it does make it difficult because I have to be able to hit certain knowledge levels to get you prepared for that. Because what we've learned is that if students are not thinking at that level, they then fail out of the program later because they can't pass assessment, because they cannot pass pharm. So I definitely will hear I hear what you're saying in regards to the caliber and how difficult it is. I am trying to bring an understanding of where the students are, but also bring you up to a level that you're expected to be at to pass your boards, right? Like it's one thing for you to pass this course and I did my job, but if I can't get you to pass your boards, if I can't get you to pass pharm later or, then I've done a poor job. So I will do my best to make it what doesn't seem to be unnecessary, but I think it's also important to understand what's needed to come out of this, like what you're expected to get from this course, which is, connecting some of those dots, and to understand that it is it does, like, you'll see like heme and cancer and lymphocytes and inflammation, and you'll see all of that in other, you'll see it in this exam, right? Because you expect it because we have gone through that. So I'm trying to, figure out how to blend the two. And it's not an easy class. And I remember my advanced patho class, it's hard. But again, passing this course is not enough to do well, right? It's not, I didn't do my job if you just pass the course and understand celiac disease. There's a certain level in advanced pathophysiology that makes it more advanced than just the undergrad advanced patho. So anyway, I definitely hear you. So I will figure out, how to do that well, like making it 90 minutes and bringing down like the size of the stem. But again, with 90 minutes, hopefully you have enough time to read through it. But yeah, how to get you guys to a level that you will be able to do well in the future courses is what is also something I need to consider. But I'll think about that. If you struggle with this material, should you think maybe using an MP, maybe being an MP isn't for asking? No, I think everyone struggles with this material. I don't think it's specific to who you should be. I think it's more so about the time needed. But I think you guys are all nurses, and as long as I think you put the time into it and build those connections, really it's just about time and then testing yourself and making, again, those connections with two different elements. And understanding at that deeper level. Don't forget you go into your, to your perspective. Right, and I think like Matthew's point is like, then you learn more when you're in your specialty. Is that what you're saying? Yeah, so definitely like my first job as an NP, my background was cardiology. When I graduated, I got into endocrine and bariatrics. They had to teach me a lot of also, but I came in with that knowledge from advanced patho and was able to then grow because of the knowledge I had from school, right? But you're not going to be an expert in that initially. I see old attendings still use Google. That's hilarious. In regards to Lewy body and dementia, Lewy body starts off with dementia and it has Parkinson-like symptoms versus Parkinson's has only Parkinson's symptoms and later on progresses to include dementia. Patients with Parkinson's are fully aware, no memory loss, functioning. It's really a motor type issue.
Gotcha. Thanks.
Definitely. So thank you, Gabby. I'll definitely take it in mind, like in developing questions, how to, and it's always been a struggle trying to find the fine line where you're not too easy, where you're not learning, and then you're so difficult that, I mean, the average right now in this class is passing, it's high 80, mid to high 80s. So people are passing, maybe they're not passing at the level they like to pass. But again, I want to make sure that we are graduating clinicians who are prepared for that advanced information that you'll be obtaining later, especially when you get to Dr. Julius Johnson and Mary Brennan, and like those courses are not easy. So I'm hoping to give you a really good foundation going in there so that you could be strong in that. So yeah, but I'll definitely try to find a happy medium in that. And if anything, come on Wednesday, maybe we could talk some things out again. I'll send an email out.
What time is this supposed to be on Wednesday?
I'll be available Wednesday between 12 and 3. So I'll send an email out with some time slots there so we could maybe spend time discussing, meeting, whatever, reviewing, whatever people need. If people want to do like a review, like in that certain period of time together, we could do that too.
Yeah, can we
Is it possible for it to be recorded? Sorry to interrupt someone.
If it's a group review, yeah. Yeah, I get what you're saying, Chelsea. If it's a group review, yeah, we could do that.
Yeah, just because I work at night, so doing something like smack dab in the middle of the day is a little bit difficult. So if it could be recorded, that would be helpful.
Not a problem. If we do that, I'll put it under the exam 3 resources. I'll list it there. I'll send an email out. Okay, well, I don't want to keep you guys. I appreciate your time. I'll go ahead and stop recording.